Welcome, everybody. I'd like to welcome you once again to our 39th UCD COVID seminar series organised. I'm Fiona McNicholas. I'm a child psychiatrist. This has been jointly organised by my colleague, Dr. Blona Gavin, and Noura Zalaji is helping us from the IT side in UCD. We're delighted also that the College of Psychiatry Ireland are co-hosting this event and these series of events for you, which I hope you've been enjoying. I can't believe we're over a year into the pandemic, and who would have thought that it would still be as real, as pervasive, as anxiety provoking at some level, but hopefully some new things have come from it. Certainly working from home is one of them, but I think the other thing has been the ability to reach out to other colleagues and clinicians, some we know and some we didn't know, from across the world. And I think really that's been one of the things that I hope we certainly will continue to save post-COVID when that happens. All of you are familiar by now with Zoom and etiquette of Zoom, so I won't spend any time talking about it, but just welcome your contributions on the chat line as we go through the talks. I'm delighted today to welcome back Mudasir Firdosi, who many of you might have remembered presented to us last year. Actually, it was quite early on acute, adult psychiatry wards and the mental health presentations and managing COVID. And Mudasir, no good deed goes unpunished, because we have asked you to come back again and not only bring that, but to bring two colleagues with you. So the talk today is 3 individual speakers presenting. We're going to start off with a talk by Dr. Ovais Wadoo, who is speaking to us from Doha. And Dr. Wadoo is Senior Consultant Psychiatrist and the Director of the Fellowship Program in Hamad Medical Cooperation. And we're looking forward to his presentation. He's also involved in an international consortium looking at the impact, both short and long term, of COVID. And I'm sure you'll talk to us a little bit about that, Ovais. The second presentation is by Mudasir Firdosi, and if you didn't hear his presentation before, Mudasir is a psychiatrist trained in Kashmir, but also in the Maudsley, and now working as a consultant in Southwest London and St. George's Trust. He is a honorary lecturer, and he's also a tutor, but he's involved also in the Royal College of Psychiatry in the Executive Faculty Meeting membership group. And lastly, our speaker is going to be Professor Arshad Hussain, who is speaking to us from Kashmir. And he is Professor of the Institute of Mental Health and Neuroscience in Kashmir. And whilst many of our speakers have both general adult psychiatry kind of interest and research, also significantly an interest in trauma. So I suppose today's talk is about just looking at mental health across the continents and getting an insight into how COVID has been affecting and is being managed by different colleagues. Ovais, over to you, please. Thank you.
Thank you very much, Fiona, for the invitation and for inviting me to present today. So I know we've got 15 minutes only, so I'll make a start. This is the topic today. Can't move my slides. Some problem there. Just trying to. Yeah, that's fine. So this is the disclosure. So the outline of my talk today is I'll briefly provide an overview of challenges in the Arab world during COVID and even before, and also briefly talk about the mental health services response in the state of Qatar. I'll also briefly try to touch on the impact of COVID-19 in Qatar if time allows. So to start with challenges in the Arab world. We all know COVID has affected everyone globally. Significant disruption due to widespread lockdown, quarantine, shielding, deaths and illness associated with it has affected billions in all the countries, and we are now close to about 2.5 million deaths. it has affected the mental well-being of all. The initial research that has come out, mainly a plethora of online surveys, is suggestive of impact on the mental well-being, not only of general population, but also specifically of vulnerable groups like frontline workers. And then there are also concerns about the long-term impact this illness would have, not only the direct impact of the virus on the CNS, but also the economic fallout and so on. So these are the concerns, global concerns. So again, if I sort of separate the concerns, so one concern was during the pandemic, and the other concern is about what happens after the pandemic. So during the pandemic, our concern mainly was, like all the countries throughout the world, as to how do we provide services to our patients, given there was widespread lockdown, curtailment of face-to-face services, there were staff absences because of the illness, there was redeployment, and then there were patient factors as well. Our patients, some of them who, when they are in a crisis or distress, or some of the patients, because of the cognitive limitations, find it difficult to abide by the infection control measures that were necessary to limit the spread of the infection. So inpatient wards and inpatient hospitals had their own difficulties as to how they minimize any breakouts of COVID in their facilities. For ambulatory and community settings, the issue was, given the widespread lockdown, how do we continue to provide services to our patients? And I think that was across the globe. And post-pandemic, again, the concern is, we know, I think sort of Lancet did talk about it. It was the theme of the World Mental Health Day as well, in terms of the underinvestment for decades in mental health. The services already struggling to meet the needs of the populations in most of the countries, especially the lower and the middle income countries. And given that there would be an increase in demand, so they'll be further struggling to meet those needs. So I suppose that is a concern again, globally. So how are the challenges different in the Arab world? I suppose the demography is different. We are dealing with a much younger population when we compare to the West. The culture is different. Here stigma is very prevalent, especially even if comparison to West, very prevalent. The first port of call for many patients would still might be faith healers rather than seeking psychiatric care. And again, services, research, workforce, has its own limitations here. And that does impact on what can be provided. I'll briefly talk about that. The mental health services in the Arab world, this is a paper by Professor Okasha from Egypt. He, quite some years back in 2012, but, it gives an overview of the services in the Arab world. People who are interested can look into that. Many countries in this region still in active conflict, which has an impact. I talked about the underinvestment, mental health not being priority in many of the countries in the region. So mainly institutional care being provided and lack of community services, and then limitations with regards to expertise in the workforce and so on. More recently, there was this editorial in the British Journal of Psychiatry International. They again reflected on the challenges of mental health in the Arab world. Again, audience who is interested can look into this paper. Looking at it, there's been some progress, but not much has changed. We still, if we look at the resources, the number of psychiatrists per 100,000, population, or the number of nurses, or number of beds or community services, continues to be a challenge in the region. Research-wise, again, this is a paper in Lancet Psychiatry 2019 by the group associated with World Psychiatric Association. Despite 5.5% of global population, only 1% of the peer-reviewed publications in mental health research come from this region. This group, identified the challenges and also proposed an action plan So there are limitations in terms of, research, which is important in terms of when we have to look at and be provided locally and what's the best evidence and culturally appropriate in the region. Specifically about Qatar, we are a small country, highest, per capita GDP, one of the highest. 2.7 million is approximately the population. Out of that, 89% are expats, out of which 60% are craft and manual workers, the blue-collar workers. We had the highest rate of infection during the first wave of the pandemic last year. And, services, again, there was a national mental health strategy back in 2013 published. Since that, there have been significant investment or increase in investment in mental health. The strategy came out in 2018. It puts mental health as one of the priority areas. So significant increase in investment, expansion of services, more community looking, forward services, more community services, and increase in recruitment and, effect on research and all that. This is for people who might not entirely know where Qatar is. This is on the world map where Qatar is, to give some comparison. I think it's about, if we compare it to Ireland, Ireland is possibly 6 times bigger in size than Qatar. I think Ireland has possibly a population of around 5 million. We have about 2.7 million here. And Qatar is hosting the 2022 World Cup and for the football. So mental health services response here, what we did. So we published this paper in General Psychiatry where we listed all that we did during the first wave of the pandemic last year. I would specifically want to touch on a few things from there. But again, audience who's interested can look into this paper. Is about the COVID-19 designated hospitals, telepsychiatry, quarantine facilities, and helpline. So I think what was different here, or maybe some other countries did this as well, was that there was segregation of patients, based on whether they were COVID positive or negative. So there were hospitals, general hospitals that existed who continued to cater for COVID negative patients, including the main psychiatric hospital. But for any, COVID positive patients, we had COVID designated hospitals, including provision of care for psychiatric patients. And we had no major outbreaks in non-COVID facilities, although there were cases both of patients as well as staff who did get COVID positive. And, strict infection control measures in the non-COVID facilities, plus, restrictions on visitation and all that to ensure that there are no major issues while we provide care to our patients. There's an interesting paper again from Qatar looking at the staff conversion into positive while working in these facilities. And interestingly, what they found out is that more staff turned positive in the non-COVID facilities rather than the COVID facilities. Again, I suppose many factors, but again, the infection control measures, the use of PPE and all that would contribute towards that. Again, it was a defining moment for us with regards to telepsychiatry. We were not using it before, so we, quickly adapted to use of telepsychiatry. We see is the video platform that we started using here, and our outpatient community and quarantine facilities, mainly any input was mostly through telepsychiatry, and to some extent the CL, the ED, and the inpatient also adapted to it some extent, and there is evidence to suggest that it is effective in all these settings. We also published this paper in Asian Journal of Psychiatry looking at the impact of the telepsychiatry in the first 4 months in last year and compared it to 2019. And interestingly, what we've seen is there was 36% more engagement. And it was, if you see the 2019, about 16,000 some patients, in 2020, around 22,000. And interestingly, again, if you see the no-show, means when people don't turn up for their appointments for new cases, fell from 43% to 11%, and for follow-up cases from 21% to 88% in June last year. So very promising, and we have plans to continue to offer a hybrid model where telepsychiatry will continue even after pandemic. Then about the quarantine facilities, again, the state of Qatar was quite clear about all travelers who were returning back to Qatar were put in quarantine facilities before coming back to the communities, including also asymptomatic COVID positive patients or anyone who had an exposure to COVID or suspected exposure were subject to quarantine, put in quarantine facilities. And we know there was a wonderful paper by Brooks in terms of the impact of quarantine and how to reduce it. And it says that there's a huge impact because of quarantine and so on. And we also, provided input and support to people in these quarantine sites. Again, in the same paper that I mentioned, it is, listed there. And again, telepsychiatry was predominantly used for that. This paper was recently published from the Qatar, my friend Nasir Masoodi and Professor Adil Bhatt. They also sort of look at, for people who are interested, how to create and manage quarantine capacity during a global emergency. An interesting read for people who are interested in this area. And then the mental health helpline. Prior to pandemic, we didn't have a helpline here in the state of Qatar, so we started April last year. It has been quite well received, given the stigma and the rest of it. People who otherwise might have been reluctant to access our services were more actively accessing our services. So it is more of a helpline and a crisis service as well. Again, we have mentioned it in our paper, but this was a new thing for us. Now to briefly touch on the impact of COVID-19 in Qatar. Professor Haddad, again, who is today with us, I'm thanking him. He's in the audience today. He led and looked at the psychiatric morbidity in patients who were positive for the SARS-CoV-2 and his team. And clearly they were looking at a younger demographics. This is the paper people interested in what happened here. Again, we are a part of our center here now, the CNS SARS-CoV Consortium. It is, representatives for more than 30 countries, and we will be taking part in this research, trying to figure out the viral impact on the brain functioning. Again, quarantine and isolation centers, we looked at the impact, Dr. Majid Al-Abdullah and his team on people in these centers, high rates of depression and anxiety reported, and it was more for migrants from poor socioeconomic groups, and lack of family contact or contact with family was an important source of distress. Again, Dr. Majid Al-Abdullah, Tom and Shuja and the team looked at impact on the perinatal mental health of women. Again, high levels of depression and anxiety symptoms reported, higher than the pre-pandemic levels. We also looked at the impact on the healthcare workers. This, again, paper did in Qatar Medical Journal. We looked at healthcare workers in the quarantine centers. Again, what we found is, only about 17.4% participants had well-being scores of less than 45, indicating suboptimal well-being. The impact was far less than what has been reported in other frontline healthcare workers. And we think partly it could be attributed to non-acute presentations, use of telemedicine, telepsychiatry. We looked at the frontline healthcare workers in the main COVID designated hospitals. There, the rates were about 30% participants had scores indicating of suboptimal well-being, and Philippine ethnicity was seen to be at an increased risk. And lastly, our chief resident and chief fellow, Muhammad Adil and Samions, looked at the impact on the residents during the pandemic. And again, high levels of depression, anxiety, and stress reported, and the residents who are more junior and female residents are at risk. So there are still more studies going on, not yet published. Again, sort of this study, which Professor Haddad and the team are looking at, the QLAMP study, general population, impact on them. I think this is not published as yet, possibly will be completed by September this year, and it will be interesting to see the results from that. And also Professor Rajiv, again, thankful to him, he's in the audience today. He is leading many studies, including this study on the suicide trend during the pandemic. Again, not published yet, but would be interesting to see the results of that. again, very thankful to both Professor Haddad and Professor Kumar for joining us today. And lastly, to conclude, I think sort of our response is that separate designated facilities, adapting a hybrid model with the use of digital health technology, and the introduction of helplines were important changes to increase access to our services. Thank you very much. This is my contact for people who might want to get in touch. Thank you. Over to Dr. Mudasir, I think, is the next speaker.
Thank you, Ovais. Yes.
Thank you, Ovais. And thanks very much, UCD and Fiona and others in the team for inviting me back. I'm glad I'm not on my own this time. I've got two more friends with me. So I think obviously we have a broad topic today and broad subject, and my talk is probably much different than what Wes was talking about with research and numbers. I think when I talked last time, it was more about what was happening on acute wards and how we dealt with things and how things were going. So let me quickly go to the slide. Sorry. 2020, I think we've got we have memories now of 20, how it started and how it ended. So when I last spoke here, it was more about not having PPEs, lots of confusion, how NHS was dealing with the pandemic and how it was affecting patients, staff, families, and people in lockdown. I think things moved since, and then we had further two lockdowns. One was kind of more kind of regional, where people were put in tiers, and then we had the main lockdown, which started later in January, which is kind of still ongoing. I think lots of things changed since. I know we have many audience from international audience today who probably may not be well versed with how the system works in UK. I think it's pretty much advanced. We have mainly community services. The inpatient service is not as much there, although there's usually now shortage of beds because we tend to treat more people at their homes. So this year was then, it completely turned upside down. So where I work is, we have 3 wards in a general hospital. We were supposed to be green wards, and all the patients who were suspected or new admissions were used to go to a different site where they would be tested. But with the Kent variant, when it came through, it just swept us. So what happened on my side is then suddenly one day, half of my patients, 50% were positive, then half of the staff, ward across the wall was 100% positive patients. The consultant there became unwell, pretty much most of the staff. Then it just sort of whole kind of I would say our trust was basically COVID positive most of the times. Personally, I became very unwell. I was off sick for 3 weeks, briefly ended up in hospital. And I think that's pretty much a story around NHS. I'm just using myself as an example. We lost many patients, we lost colleagues. So it wasn't easy. And I think all the preparation we had, like at the start, we thought we didn't have PPE and other things. Now we had things in place to a larger extent. And I think we thought we knew what we were doing and we had protocols. Nothing worked. It just came, and from a very green side, we were the most red side in Southwest London, because I think we were reporting at one point the highest number of kind of COVID positive cases in London. So gradually, I think things have moved on. That led to many difficulties and problems, as I will be talking about. So I think I already touched on this. So many staff went off sick, patients were off sick. And then I think that also led then to, again, because we don't have time to discuss this, a lot of disruption in the sense that people got stuck on board, they had to be isolated, which fairly worked. Again, I think most people, even when they are not mentally well and were not reasonable most of the time, they would still work with it rather than not work with it. So how did the services kind of changed or worked with this whole pandemic and the numbers, I think obviously we all know UK is topping the charts, at least in Europe, or kind of on top in the world. So predominantly, I think that there was changes in demand, delivery, and capacity. With the start of pandemic, clearly with the lockdowns, I think people almost either stopped seeking help or only went to A&E or a casualty. Things got out of hand. Usually with the general practitioners working remotely, I think it again became difficult for people to seek help. So there was a lot of reluctance on that. I will be showing some sort of numbers later about what has happened. And changes in delivery, as we're also talking about, I think apart from inpatient services where we had little choice, we had to work face to face, most of the community services went remotely. And I think that has its own impacts on how patients or how people could work with that. I think although we do have internet and access to technology in the country, but I believe there are still patients without smartphones or without kind of having those means, and those patients are probably more vulnerable. And I think it also impacted the capacity with sickness, with moving people from mental health services, which was done again in at least in England or London, I would say, that our foundation year doctors were transferred to acute setting repeatedly. So and clearly the mental health there took a backseat a bit, and then staff sickness was quite predominant in the sense that that also changed the capacity how we were delivering our services. This is kind of if you look at this graph, this is from NHS benchmarking, which collects data from most of the UK, and this is kind of last year. And you will see that I think overall the admissions are same or pretty much they have reduced. There's not much change. So there were more in kind of 2019 and now, and still into December 2020, there's kind of still 7% reduction. Although I should say in my trust, we have not had a bad in last 2 or 3 months. We were 100% capacity. So I think this is national. So quite in contrast to what I see in my trust. And I think then this was something which was worrying. I think the deaths of mental health patients almost doubled, which normally if you relate data from previous years to 2020, there are COVID-related deaths. This is from CQC, which collects the numbers of those who are in a mental health act. I wasn't actually able to find out those patients who are informal, were they included in this or not. I need to clarify that just to say that. But this is for detained patients. So the numbers have almost doubled there in terms of deaths, and I think it brings again a huge amount of stress because we don't expect deaths on our wards. Our nurses and staff are not used to it. I think this is something very unusual for it, and I think it created its own stressors among the workforce, how they dealt with the pandemic, and at the same time the increased mortality and the morbidity which came with it. I wanted to touch a little bit about the community services. Obviously, I'm not a community psychiatrist, but I think this is interesting. I think we are there are lots of surveys, reports, papers are being published, which I didn't want to quote here, of increased incidence, prevalence of all the mental disorders, predominantly anxiety, depression. But when we look at the referrals to the community services, the trend is there is a decline. Now, what are the reasons for that? Is it just because people are not seeking help because of lockdowns, or they are not able to seek help because everything is remote, or they are not able to go to their GPs, or they are avoiding going to A&Es? So you can see the changes. Like we are still down by 14% compared to the previous year. Although I think there was some recovery after the first peak in infections, but then it went back down. And this is the contacts which is fairly remained, I think almost same, not much change there from the community services. this is just adults and older. I haven't included the CAMs and others here. And I think this is the percentage then delivered kind of nationwide, either, what do you call it? Sorry, let me quickly share this. Face-to-face or online. So I think most of the community services almost kind of, it certainly got upside down. So around 60–70% started with online. Yeah, this was how it's still. So most of the contacts are still non-face-to-face, which could be telephone, or it can be now video. There's some recovery, but predominantly it is still working the same way. And I think if we compare different services now, the children's services and children and LD services seem to be predominantly taken up the online consultations, probably because children like and they use the gadgets, but it's not that much in compared in the general CMHTs per se. So I think just I wanted to reflect a bit here is, are the real numbers really going high, or we are serving a population which is under lockdown, which there's a lot of fear. There are lots of other worries, job losses, economical issues, probably relationship issues, because people are into each other's faces all the time. And if they are filling in a survey, are they really depressed, anxious, or something is going on? I think probably it's hard to answer that question now. The other question in my mind is that being psychiatrists or working in mental health, are we really going to go non-face-to-face? How good is it for us? And what would be the future? I think those are the questions. But as things stand, we are still, as inpatient services, working full on face-to-face. Community services are still predominantly non-face-to-face. I think still the prediction of tsunami of referrals, which was come from Royal College survey and other surveys, hasn't actually come through yet from the numbers. But at the same time, if you talk to colleagues around, they would say they are struggling, people are off sick, the numbers have built up, they're not able to sort of see people on time, there is kind of delayed in consultations, and we know that the huge, big NHS backlog, which is just not only psychiatry, that is everywhere. I think I will stop there. Probably we'll have a discussion later in a Q&A. And this is my email address as well, just in case. I will pass on the mic to Professor Hussain. Thank you. Arshad.
No, it's good afternoon, probably in airline. It's good evening here in Kashmir. I think the slides are visible.
Yes, thank you.
Okay. You know, quite contrary to what the places Ovais comes from and Mudasir is working in, we belong to a low economic zone with very limited mental health facilities, and most of them which have been developed in very recent times. This is one of the pics taken by my wife after we both came back from work. She happens to be a gynecologist, and we, by walking on famous Dal Lake, only two of us. You know, it is usually flooded with people, but that day after we came from our outpatient departments, this is really, nobody was there, and this is probably in April, May. All of us know that when the pandemic struck, most of the mental health services throughout the world got hugely disrupted. And disruptions were, one that there were restrictions because of the pandemic. Obviously, mental health services had alternatives as well to be like telepsychiatry was developed in many places already in the world, and those services were availed. But besides those all things, in our parts of the world, they were not the only kinds of disruptions. You could see on the slide the kind of disruptions which were reported by WHO in June, August in the mental health services in the different areas in the world. But and this is the Indian scenario. This is a paper which was published in the Indian Journal of Psychiatry, which again talked about the disruption of various services, and there was huge disruption, and this is very well known now, from major disruptions in outpatients, electroconvulsive therapies, psychological therapies. Almost everything was disrupted because of the COVID pandemic. We in Kashmir, our first case of coronavirus was diagnosed somewhere in mid-March, and this led to disruption of almost all health services, and mental health services were no exception. In fact, there was more disruption there because of few more reasons. What Mudasir already said and what Ovais already said, the disruptions of that kind and the disruptions of new kind, because almost all buildings which were where mental health functioning was done, for example, the district hospitals were almost turned into COVID facilities. All of them were turned into COVID facilities, and mental health facilities in them actually got closed down. Then there were mental health facilities in private sector. They all got closed down. In some places like, we have in the state of JK, we have these two divisions, Kashmir and Jammu. In Jammu, the mental health hospital per se was taken to be a COVID facility because of limited facilities available. This is one of the high state officers, divisional commissioner of Kashmir, coming to our hospital to actually have a survey and to think of actually taking this over as well as and creating a new COVID facility in Srinagar, because we had a newly built hospital which had about 100 beds. It was still sort of, we just started outpatient services there, and they thought this is very opportune to actually change it into COVID facility. And this is me and our principal medical college trying to resist and trying to logicalize with them that how important the mental health facilities will be, and this facility, how important it will be at the Institute of Mental Health, with all the mental health facilities almost in the all state getting shut down, and this remaining the only facility probably we need it and we should not change it. To our satisfaction, we were able to convince the divisional administration, and they let the hospital function as a non-COVID facility, as a psychiatric facility, and we continue to work. Even though our other facility, we have a major psychiatric hospital, it's only psychiatric facility. Besides that, we have a general hospital unit as well in our main hospital, which actually houses a day addiction center, a child psychiatry center, and a consultation liaison services and general OPD. That building actually was instead taken away as an isolation facility for COVID suspects. But this, our main institute was spared. And that proved to be very, very prophetic with the words we actually had talked to divisional commissioner that day. This is about an Institute of Mental Health. This happens to be one of the only residential facilities in whole Kashmir division for psychiatric inpatients. Besides actually taking care of acutely ill patients, we also do have lots of patients which are chronic with us. For about 40 patients which chronically live with us for a long time, in absence of halfway homes, in absence of rehabilitation homes, most of them actually live with us for their, not only for the psychiatric needs, but for other needs as well. And we were really worried about this lot because we had already have had some of the papers which were coming from Wuhan, which were talking about, huge death rates in the initialized patients, and particularly the mental health patients. Our outpatient within that month of March, our outpatient facilities started increasing from 200 to 300 patients almost every day. This was actually just because of it was no increase because of COVID, but it was increased because all other facilities were just closed. One, that we had our own patients coming, and second, that all other facilities were, so they had nowhere to go, so patients will come there every day. So we were almost forced to actually start the physical services. We were nobody had any clue throughout the world what should be done, or how do you actually run your outpatient services. Most of the outpatient services in our part of the world were also closed. We were thinking of alternatives. Mainly we were thinking that probably we will have to take care of our chronic inpatients, but that didn't happen. The patients started coming, and we had around 200 to 300 patients every day coming. So the first, we started doing the same things as everybody was doing, checking temperatures, making people to sit as far as possible from each other, opening the open spaces. Like we had a solarium, we had gardens. We opened them for patients to sit so that they maintain distances. Did the measures as we could in this number of patients, and we started seeing patients physically. Right from the beginning. This is right from the beginning in the March. Inside consultation chambers, we usually, doctors in a normal chamber will wear a mask, and many of us will wear a double mask, and N95 with a surgical mask on it. And we usually worked with distances. So we had a patient at 3 meters distance, and he will generally will have a surgical mask. Many non-governmental organizations donated us these masks, and we were able to actually put on almost every patient which we see. And in case somebody needed a physical examination, there was a separate room for that. And in that room, we usually kept a resident who will have the full PPE gear, worn. These things seem to these things seem to be very, very small things at this moment of time. But at that time, when there was complete vacuum of lack of knowledge, they were steps taken by us without actually knowing that whether they will be effective or not. So that time, these small things seem to be very, very big. This is probably outpatient. In last April, one of our consultants actually seeing a patient in outpatient settings. We generally discourage the new patient in the chronic settings. Most of the admissions we try to do in the family settings. We have family wards, which are open wards, wherein there is no connection with the already, the chronic wards we have. So we discourage people to actually put patients in long-term initialization. Instead, actually try to give as much as acute care, so that patient, once they get well, they're taken back with the family. We generally what we did is that admission, we, after we had rapid antigen tests available, we started doing, rapid antigen tests before every admission to the patient, and initially for the when there was peak occurring here to the attendant as well, and subsequently, if there was anybody who needed long-term chronic infection, admission without family, we isolated him for 5 to 6 days, did his RT-PCR, and then only did we put him in the chronic ward. Right from the beginning, I think we were lucky that we had RT-PCRs available right in March, because 2 of our departments had these research projects going on RT-PCR, and they had just, as soon as the reagents arrived, they were able to actually do tests. So we were able to do lots of tests, and in those we also did testings in our chronic wards. 3 weekly testings of. We had 5 chronic wards, and we will do 1 test from each ward, thinking that that will actually determine that whether there is any infection there, because they will share washroom, there will be common, everything was common, these were like general wards with beds together, and wherein they will share almost everything. And obviously, many of them have disorganized schizophrenia, and mask was masking them, or making distance between them was impossible. And by this testing, we continued this after every 3 weeks. we try to see that whether we have been able to keep infection away from our chronic wards, because we were very, very afraid of that with the kinds of news which were coming from the West about the industrialized patients. So we were really scared about them, that the infection should not go in any of these wards, and that will make it very difficult for us. And there were no designated facilities for mentally ill COVID patients, so that would even make worse for them. So the lucky for us, we have still, fingers crossed, we are now 1 year, we did not have even a single infection in any of the wards. And we did not only check them with RT-PCRs, we had regular seroprevalence checks. And in these 42 patients, we have, even though the seroprevalence in many parts of are approximately 50 to 60%, also now and average over 45%. But in these wards, we were able to, we had initially had 2 patients which had antibodies, and one of them, and both of them actually had this prior to actually their admissions. And that's why we maintained it. And there was no fresh increase in the seroprevalence or a fresh RT-PCR determined, detected from these wards. One of the services which actually we ran and which was actually closed at many places was electroconvulsive therapy. Some degree, some of it happened in that rush. We were actually looking at inpatients, we were looking how to send outpatients, and electroconvulsive therapy actually happened, in initial weeks of May. And then we thought of actually making it as logical and rational as well. We did not have, we knew that this is an aerosol producing area. So what we did is that everybody took precautions as were generally, talked about those days by either by WHO guidelines or some other guidelines which had actually come in place. We just took those precautions and continued with electroconvulsive therapy. We did subject patients to RT-PCR before actually going for testing. And once the rapid test was available, we also did it before every sting. We did the rapid testing. Until now, we had to actually postpone, I think, 3 or 4 patients which were detected just before starting RT-PCR. But none of the staff members of ECT actually developed, RT-PCR positive COVID symptoms. In fact, I don't think, now we are vaccinated as well. Their serum antibodies also came at least 3-4 times negative, because we did check seroprevalence in our employees as well at different points of time. Even though employees in other areas had higher seroprevalence, as probably Ovais also said, that has much higher seroprevalence than was in the COVID designated hospitals. Telepsychiatry was unknown in our place, absolutely unknown. And in that rush, we also used panic, because it was getting so difficult with the kind of news which were happening. Our colleagues were getting admitted from other branches in hospitals, and there was some loss of life as well. That did panic us a bit. And we were actually trying to set up as many telepsychiatry services as possible in that. Some non-governmental organizations helped with phone lines. Then many of us started using our own phones and started seeing patients through WhatsApps. And these small digital clinics became hit. I think the data which we compiled in November had me doing around 18,000 consultations over this period of time, along with my unit. So we had actually set up this. Besides actually physically seeing around 70,000 patients from March to December. That's what we were actually doing during this whole time. Yes, we had cost. I'm not saying, most of the faculty actually developed COVID. Many residents did develop COVID, but luckily, because the kind of protocols we had set in, there was the inpatient setting still remained off it. We did not have spread in the inpatient facilities, and the kind of protocols of once somebody reported sick, he stayed home, and the masking and the distance actually prevented any catastrophe to occur in our hospital. This is 2 settings. I've taken permission from this patient to actually share this. this is actually we seeing a patient in digital setting, and this is how we used to see physically. Physically, patients used to feel very uncomfortable because this Eastern way of looking at doctor, and you should look at him, and when he sees at you, then you feel better, was not possible during the setting, and they couldn't come. And these old ladies which have this habit of putting hand on you, sometimes even kissing your forehead. That was not done. It seemed many times very bad to them. But once they used to come to the digital clinic, they generally used to have a laugh and smile at doctors, and feel like that this is the real kind of how a patient can be seen. This is how our hospital actually did the other things. This is me writing about stigma very early in this place. Probably one of the first articles which was written that COVID actually could generate as much stigma as tuberculosis, leprosy did at its times. And probably this was one of the first articles which was on stigma. I don't think there were any article probably written on stigma at this point of time. This is, we making various advisories for people. And one of this became very famous here, what we call as Dialogue in Darbar. This is a very traditional way of actually talking to each other when there were floods and when there was inclement snow or weather. People used to talk through windows. And this was called Dialogue in Darbar. And we put it that, you could still be socialized, people could still socialize by talking to each other and maintaining distances. This became a hit at our place. We continued our, Zoom actually came as a boom to our PGs, and so we could utilize, because the lessening of clinical work meant that we could actually have more of classes, and Zoom became sort of a hit, and we could have PGs interacting more case presentations happening, more discussions, more symposia, and they continue. We are continuing with this kind of, we still utilize Zoom for most of the education purposes. This is some of our research which will be present in WPA World Congress of Psychiatry, talking about seroprevalence. We have a research on COVID delirium, which probably will be one of the biggest series which has been seen, where we have tried to delineate patients of COVID delirium with different causes from our consultation liaison services. This is we also try to look at what happened to psychiatric patients who already were on treatment, and when COVID struck them, what was their mortality and morbidity. We are still looking at it. The small pilot of it might be presented there. We looked at new onset obsessive compulsive disorder, whether they were or they were not. We also looked at seroprevalence at long-term in the psychiatric cases. We continued with our consultation liaison psychiatry, particularly through the tele-facilities, and we provided consultation liaison psychiatry to almost all the medical wards, the COVID wards, and in fact to the quarantine centers initially as well. We were probably only addiction center in whole India which continued its addiction services, because we were caught up because we have good number of addiction population. There are no private services available here, unlike other parts of North. Even the premier institutes, PGI, AIMS, NIMANS, stopped their services in addiction, but we didn't have that luxury. We continued with them, and we are still continuing with them, even though we shifted addiction center to our main hospital. Now, the OST also, all substitution therapy centers also continued. We almost became self-sufficient in screening COVID. We had COVID testing facility inside us. We had seroprevalence very easily available, RT-PCR, RAT. Our larger medical college helped us a lot, because we were actually the only non-COVID facility which were running. So we were self-sufficient in that. In fact, we provided this help to the local population as well. This is summary of services as has been till December, wherein I already talked about the number of outpatients and inpatients we had, and the addiction services we had. So this is the summary of the services which we provided physically during the time of COVID. This was one of the acknowledgements of our hospital's work by one of an international papers. And I want to conclude. We still do not know the best practices which should be followed in COVID, and in fact, we should be lucky that this never happens again. We never have to, and probably in most of the people's times, the pandemics come once in a lifetime. But we do keep learnings for our posterity there. So we still have to probably formulate the best practices which could be done. And many of the areas where the work continued might be the best sources where we could actually help in formulating the guidelines, how they should be. I know that we were forced to do this kind of work. You know, nobody expected the physically to see patients in March. There were 200 at the outpatient, but because we were forced, and we were able to render these services did continue. And that's what probably might make us to learn, because currently we now know that distance mask does help in decreasing the infection. At that point of time, most of this was unknown. You know, you were even scared of the empty tables, you were scared of the prescription, you were scared of almost everything. But now, you know, most of us are relaxed, and we know that distance mask and sanitizers do help, and we probably need to continue it. We are at the conclusion, you know, we hope that the pandemic subsides soon, and you know, things become much better. But you know, the learning which it has given to all of us needs to be passed to the posterity. Thank you so much for letting me to talk and inviting me.
Thank you, Arshad. If you could unscreen, or maybe Nora can exactly put everybody back on. Thank you so much, Arshad. And it was lovely to actually have the noises coming through in the video. For a brief period, we could only imagine what all your countries must be like, because sadly, we are all stuck here in our lovely country and just hoping to get out sometime soon. There was a question that was asked. Jerry McCarney, who's been lucky enough to actually visit your country, compliments you on the beautiful geography, lovely country, the people. But I suppose it reminds us of both geography and politics can make it difficult when you're dealing with infections and dealing with trying to make sure that everybody gets equal access to services. Could you say something about that, whether that was a particular hindrance in your initial management of COVID?
No, you know, I think besides these initial hindrances in terms of, I mean to say that logistics, that whether our hospital will be allowed to work as a non-COVID, I do not think beyond that there were many hindrances. In fact, there were many things which were facilitated, because whatever we needed was provided to us. The other departments did cooperate to us, with us, because everybody of them knew that the kind of work which is happening there, because all other departments were just static, you know, surgery, you know, nothing was happening. But this department, you know, you had patients coming, you had admissions happening. So our dean was actually know of that. She had actually asked, the government also knew about that. So there was lots of facilitation, in fact, during all this time. You know, as I told you, that even our RT-PCR service, our RAD service, you know, even though antigen testing, you know, you had to, you know, there was sort of rationing of these antigen tests, but we were liberally given, because they knew that the number of patients we are treating and number of patients which are coming to the facility.
Okay, thank you, Arshad. You might like to put your picture back on if you can manage that. It's nice to see you. Ovais, lovely, you might have forgotten. Ovais, there was a question from Ayan, I hope I'm pronouncing your name correctly, who was complimenting Qatar on their response to the infection initially, but then just wondered a little bit about, you know, whether you've any idea of why there might be a recent increase. And I guess, you know, this applies to many countries where initial low infection rates, you know, have sadly been followed by surges, whether it's 2, 3, or 4 surges.
Thank you for the question. Again, I think sort of I wouldn't be possibly able to answer this question. Again, sort of there has been new variants coming in, possibly ease down of the lockdown. You know, people were a bit more than, or they were, you know, stuck for a long period of time, and then the restrictions were eased, new variants came in, and the rest of it, like globally, most places had the second wave. That possibly, you know, could have contributed to that. But possibly, you know, people who are directly dealing with, you know, the tracking models and the rest of it would have better, you know, understanding of as to why we have these second waves and so on. But my understanding would be easing of restrictions, new variants coming, and the rest of it leading to the surges again in almost all the countries.
Okay. And Mudasir, not really a question for you as such, but in the beginning, you know, there was this real international collaboration and kind of everybody looking up, well, beginning to think about everybody else and making sure that we were all in this together. More recently, we've seen a little bit of tension, I guess, with, you know, vaccines being held up in the UK, delays in vaccines, Italy, you know, not sending vaccines to Australia, a little bit of tension between the EU and other countries, and other vaccines holding on to other countries holding on to vaccines and not using them because, you know, they weren't satisfied with the data, but yet many other countries not any. Do you worry that the initial collaborative spirit maybe is being eroded as time goes on, or do you think we can get back there again?
I think you are right. I think we are mirroring the typical disaster response where initially there's a disaster somewhere, everybody comes together, they support each other. And if it carries on for a long time, then everybody starts thinking about themselves more than others. And we also become complacent and other things. I think that has happened. I think it's not a news we hear every day. I think that many African countries who can't afford to buy the vaccines don't have it, and some countries have access of it, and they are trying to sort of say they will donate it to poorer countries. So clearly, it's a pandemic. Any human being can be infected with, despite race, color, religion, doesn't matter. So I would think that we will become more reasonable, rational long term, but I think that's how it is. And obviously there's a huge part to play with politics and economics in this whole thing. It's not just a health problem. I think that will dictate the long-term sort of solutions as well. Clearly, we as professionals only try, others like sense giving evidence or providing, but then the decision makers are somewhere else. Probably those rooms are not, those boardrooms are filled with different people who obviously look at different things. So it's probably a bigger question for me. I'm not a politician or economist, but I agree with you. I think the fairer it is, the sooner the pandemic may be over. But because if it continues in pockets, then we will have new variants. They will travel around as usual. So unless it is curbed in a go everywhere, so that it dampens down and we don't have new variants and new transmissions, it's likely then we will have more and more types of variants if it's only like one area gets vaccinated, not others. Yeah.
But I guess with the worry about new variants, you know, comes the impetus to make sure everybody is vaccinated as quickly as possible, you know, to kind of minimize that spread. And I guess, you know, those that shout loudest or has the largest clout or the most power, you know, seem to get most. Ovais, there was a question with regard to the percentage of expats in Doha. You know, the specific question was whether language was a barrier, but I also wondered whether, you know, I suppose differences in access to services might also have been something that your country had to worry about or try and make sure. Did that happen as it happened in many other places, the disparities? Was language a particular issue, or?
Thank you for the question again. Yes, sort of again, you know, as I mentioned during my presentation, we have people from about 150 countries who live here. So many languages are spoken. If we, you know, see Arabic, you know, is mostly the language of people from Middle East and North Africa. So the Arabic speaking people here roughly would be 40% of the population, and 60% of the population are the non-Arabic speaking, who are usually migrants from across the world, a minority from the Western world, and a majority, as I mentioned, the craft and manual workers and the rest of it from Southeast Asia and East Asia. So you would have a good number of people from Indian subcontinent, India, Pakistan, Bangladesh, Nepal, Philippines, so quite a good number of population. As I said, sort of the services response, or how the services, you know, in the recent years, the investment, the recruitment and the rest of it, both from the psychiatrist point of view and as well as other professionals, including nurses, almost all teams have a mix of professionals who speak various languages. So you have teams here where, you know, there are Arabic speaking doctors, nurses, there are non-Arabic speaking, Hindi speaking, Pashto speaking, Kashmiri speaking, most of the languages are taken care of. So that does help, yes. But language, we know even in the West, there is sort of a lot of reliance on migrant workers in terms of professionals, many doctors, psychiatrists, and the rest of it who come from other parts of the world. Then there are issues around, language, cultural sensitivity, and the rest of it. But I suppose here, given sort of mental health is one of the priority areas, a significant investment has gone into recruitment and the rest of it. So we have almost in all teams that I can think of, so a mix of professionals who speak many languages. So that by and large takes care of, the language issue.
And just you mentioned there that there has been specific investment in mental health. Some, and indeed we had one of our own colleagues who published in the Irish Journal who had spoken about that maybe in some ways the realization that COVID is having such a detrimental effect on psychological health and well-being in some ways has allowed services to prioritize mental health and might allow new development. Do you think that might happen? Might that be one of the benefits of, the new investments and getting services up and running, and maybe more willingness to talk about mental health and the sequelae?
Thank you. Again, I completely agree. I think and I hope that, that is true. Given what I have seen locally, as I said, given there was, the national mental health strategy followed by I think what is important, the country needs to have a vision, a strategy. All of this could not have happened just when the COVID, we were, in the midst of COVID. I think to change all of it is so difficult, to get those resources. Given that was about 2013, there's already investment which had gone into provision or recruitment and provision of new services. We then possibly, this is a moment which would further, advance those changes and, the need for that investment in mental health. But definitely, there was support from the strategic group that was overall looking at the COVID response, that mental health is integral to it, and was supported to adapt and possibly start new services. As I mentioned, the helpline or the crisis line was not there. So again, it required a lot of resources which were supported by the state. So that is the telepsychiatry, I think it was a defining moment, as I said, and given the numbers we've seen and the cultural sensitivity in terms of reluctance possibly for face-to-face, that will continue post-pandemic. Again, that's a huge resource, proper video conferencing and the telepsychiatry and availability of in each center was supported. And then these quarantine facilities, I refer to that paper, many, centers were sort of extensions of healthcare with similar sort of protocols in place. So yes, I think, yeah.
They often say a crisis allows you to do things that otherwise would not be possible. And the red tape, that might exist for so long, is loosened. Mudasir, there was a question from one of our colleagues, Anne Jeffers, who talks about, although accepting the benefits of Zoom, and that is one thing that has come with the crisis. People have been trying to do telepsychiatry for a long time, particularly in the States, and there was so much red tape that now it's everywhere, which is great. But Anne's point is that, when people come to the emergency departments, one of the things that they do say is that they're missing the face-to-face contact with their clinician. So is there a sense within the UK that, Zoom is beginning to have its limits even now during COVID, that, it might be safe to continue to have an appointment with Zoom, but maybe there's a need to do some, staggered or, bring in some face-to-face as well?
I think my sense is that there's a danger, isn't it? So if we look at the rest of the world where obviously the services are not as developed, I think here the danger is reversed because NHS is struggling with finances from a long time. There's always kind of what we call as efficiency savings or cutting the costs. One of the means is doing more remote work, is saving office space, asking people to work from home, things like that, which may work in some specialties. But I think psychiatry is something where something about face-to-face, not always kind kind of working remotely. But I think then there's a mixed bag. If you look at the younger generation, the CAMS numbers are the very high remote consultations that they seem to be feedback from the colleagues, they seem to be liking it, or from LD service, other services. But I think we ought to have a balance somewhere. I think if we just push, because there's a lot of push of, I'm talking of my trust, other trust, talk of having offices or mobile offices, or not even having an office now. So you have your laptop. If you are not working on a ward and you are a community setting, so you basically can work from anywhere, from your bedroom. I think that I see a danger between sort of saving money and kind of encouraging this kind of remote working. But I think it may work in some places where there's less manpower. Like I have worked in Kashmir or some other places where I think if you have telepsychiatry, it may be great because you cannot reach some areas. But somewhere like in England where you have got services everywhere, and we are going other way around now, that we want to encourage it because it may save us some bucks, is the danger to me. And I think overall, I think our patients do like to see us, and we do like to see them. That's why we're in psychiatry. That's my sense.
Yeah.
So yeah, there's
I guess post-COVID, what will be important is, you know, to keep the positives, but to make sure that we have actually asked all the different groups you've mentioned, whether it's child, adult, old age, and the clinician themselves, you know, the effectiveness of the Zoom. It may be practical and cost saving, but whether it's therapeutically, you know, the best. I'm going to end with two quick questions.
Can I reflect on what Mudasir was saying?
Yes, please. Is that Arshad?
You know, about introduction. About introduction of, you know, things like telepsychiatry in places like ours. You know, I tell you that, you know, I fully agree with Mudasir that there is something in psychiatry where people, you know, because now we have been running this service so long, there's something in psychiatry which makes people to feel that once they come one in touch with doctor, it's better always. And this is a general feeling. But on the other hand, I tell you that what I found during this during this year, that I reached to families. I remember this one family in a remote North Kashmir area, where this girl who herself studies in a university, does a post-graduation, had mother and two brothers in hospital because they just will not agree. And you know, she learned about this kind of thing, and she contacted us, and we were able to see, and we found them that, you know, we did an assessment and found that all three of them had schizophrenia, which was never treated, and the treatment was started, and you know, I could have been able to share the joy and happiness of that girl after 2 months, when the mother started talking to her normally, when she had a cup of tea cooked for her, when the brother started becoming non-violent. You know, she was sort of so happy at the home. She said that till then she wanted to stay at the hostel only, never come back home, because it was so difficult to actually, you know, live in the home. So, you know, in our part of the world, so we might be able to do that kind of work, utilizing the technology, but still the essence of, because we as psychiatrists should always, you know, propagate that the essence of human civilization is being social, and the essence of human civilization is being together, and the essence of human civilization is being in the real world and not in the virtual world. When we continue to be only in the virtual world, we cease to be humans. We, you know, as they say, we change from Homo sapiens to Homo Deus, and we all should pray and, you know, long for continue being Homo sapiens and not become Homo Deus anywhere in the world.
Thank you for that, Arshad. I was going to ask, there's a number of questions I haven't got to, but I am fearful of taking up your time. And also your point about we are social beings. I think many of you are good to put up with the virtual COVID, and it's time to get back to your teams or whatever. I had wanted to ask, but we'll speculate about, you know, whether clinical profiles are different in your countries during COVID. You know, is there a certain increase in different sorts of presentations, or indeed by age groups? You know, there's kind of different results about, you know, whether numbers to CAMS, for example, are increasing or decreasing. And one of our colleagues is mentioning even post-COVID, a lot of new onset problems that children are experiencing, but we won't have time, unfortunately, to address those today.
I can say,
yes?
you know, two sentences.
Yes.
That, because, you know, we did some data analysis. We found that, you know, one, that most of the people who sought help during this time were either already diagnosed or had a new onset problem, which probably was unrelated with the COVID. But there definitely were certain things which happened which could not have probably happened. And one of them was, you know, few new onset obsessive compulsive disorders wherein people had OCPD-like features lifelong, were compensating and had, you know, sort of a breakdown. And then we also found out this new entity, you know, post-COVID delirium in lots of patients who were discharged, lots of elderly patients which were discharged from hospitals, you know, had RT-PCR negative, had oxygen normal, but still continued to be in delirium for long durations of time. Besides, you know, initially in people who were actually put into isolation and quarantine, you know, against their will, we did find in some of them, you know, fear of certain degree of COVID.
Right.
Besides that, you know, we did not find any other trends as yet.
I guess, like most things, data and studies will continue to emerge, and we'll continue to learn from it. And what we learn from COVID might actually then, you know, have a huge impact on etiologies of you know, some mental illnesses. I'm going to have to thank all our speakers profoundly for speaking today. I'm going to thank the guests. I'd like to draw your attention to our talk, I'll say our treat for next week. I hope there's a lot of cooking in it, but it's COVID couples and cooking. So I hope that you might attend us next week for that. And also I want to highlight again work that our colleague, Professor Liz Barrett, is doing, actually, yes, in the UCD Mind Reading Project. So coming up later on this week, Plagues, Panics and Physicians. So thanks everybody, and have a good weekend, and see you soon. Stay safe.
Thank you very much for inviting me.